we have today joined us all the way from America, I believe, Professor Allen Frances, a very well-known, one of the leading psychiatrists in the globe, in the entire world. He was the former chair of the DSM, DSM-4. He has been teaching, lecturing, researching psychiatry, mental health for probably over 30, 40 years. Please correct me if I'm wrong. He's written a number of different papers, research, also books. One particular book that we'll be discussing today is called Saving Normal. So welcome, Professor Allen Frances, to Psyccorner podcast.
Special pleasure for me because Arab psychiatry, the Muslim world in psychiatry, was 1,000 years ahead of Europe in creating wonderful psychiatric hospitals, humane treatment of patients, beginning of cognitive therapy, correcting a lot of the anatomical mistakes that have been made by the Greek and Roman world. So that it's a pleasure for me to give back given all I've learned from you.
Thank you very much. I really appreciate you giving your time. I know you are very, very busy and we have only about half an hour. So thank you again for giving us your time. It's a real pleasure. I've been following your work, reading your books for a while now, and have learned greatly from your work. Although we have not met, we've met online. So it's really, really an honor and pleasure to have you on this podcast. I just want to first question ask you about your involvement with the DSM, being a chair, how that came about. What was I know it's a long discussion, but very briefly, how that came about and your experience in regards to that, really.
Well, the short version is I started working on the DSMs in 1977 with DSM-3. I was head of the task force for DSM-4, which was published in 1994, and I've been very critical of DSM-5. I think the diagnostic system is very important, but easily misused. And the current diagnostic system has a systematic bias in it that the definitions are too loose and the clinicians apply them too liberally. So I've been on a kind of crusade to try to reduce the tendency of clinicians to overdiagnose people who have the ordinary distress of everyday life, that life is filled with sadness, anxiety, frustrations, and disappointments and grief, especially now with COVID. And that these feelings are evolutionarily built in, that we should only diagnose psychiatric disorder when there's clear-cut, severe symptoms that can be reliably diagnosed, that cause significant impairment and distress, and that we have treatments for.
Thank you very much. And obviously you said you've been a critique of the psychiatric field or the diagnostic area. You've written a book called Saving Normal. And in that book you discuss about pandemic, really, one can describe about prescribing, the over medication of mental health in America and also in the UK and other parts of the world. And what made you write that book? What was the impetus behind it?
Well, I think that done well, psychiatry is a wonderful service. And we terrifically neglect the people who most need the medications that we have to offer. So in the United States, we have 650,000 people with severe mental illness who are either in jail or homeless because they don't have sufficient access to community psychiatry. It's much better in the UK, but you have similar problems to a lesser degree. Yeah. At the same time, and paradoxically, that we're neglecting the people who really need us the most, we're over-treating people who are the worried well. So in the United States, we have 20% of our population taking a psychiatric medication every single day. That about 12% of Americans use a antidepressant. In women over 40, it's 25%. We have about 7% of our kids on stimulants. There's a great overuse of antipsychotics, particularly in kids and in the elderly. So I think that we have to address the fact that we're not giving the right treatment and sufficient treatment to the people who really need it. And we're overdiagnosing and over-medicating people who do better without treatment at all, with watchful waiting or with psychotherapy.
Right. Yeah, absolutely. One of the questions that I think some people had in mind was that, in your opinion and your discussion and also research, I mean, in particular, probably in America, in the last 10, 15, 20 years or so, there's been increase, as you mentioned, of prescribing antidepressants and other psychiatric drugs. At the same time, it appears that some of the pharmaceutical companies and the R&D departments, they've not really invested that much as before in the last 10, 20 years. But prescribing antidepressants has increased in the UK. I know it's increased in Europe, and I'm sure in America and Canada and other parts of the world. Why, do you have any thoughts on that? Why do you think that is?
That's a really great question. I think the huge investment in pushing psychiatric medications began around 1987 in the US with the introduction of Prozac. And for the next approximately 15 to 20 years, there was a tremendous effort to sell doctors, to make them much more aware of the medications, to make patients aware of the medications, to increase the sales of these drugs. When the patents run out, and it was clear that there's no magic bullet, that there have been no more effective drugs created in the last 60 years, that the original drugs that we had in the 50s and 60s are just as effective as the current ones. They have a different profile of side effects, but the efficacy is not improved. And the drug companies had spent a lot of money in research and found that they did not come up with blockbuster new drugs. All the new drugs were Me Too. They got out of doing research in psychiatry and stopped pushing so hard with the salesmen, seducing doctors into giving medication. But that didn't stop the increasing growth of medication use. And I think the reason is that 80% of psychiatric drugs are prescribed by non-psychiatrists, by GPs, by pediatricians, family doctors. And they are under tremendous time pressure to get the patient out of the office happy. The emotional distress is probably the leading chief complaint for patients coming into general practice. And the easiest way to deal with it is to just write a prescription, the patient leaves the office. So the tendency has been, for psychiatrists to some degree, but even to a greater degree in primary care practice, is to resort to medication for the kinds of problems that often go away on their own or are much better handled with watchful waiting or with psychotherapy. And it becomes the way of conducting an efficient practice, but not necessarily the most effective practice. And patients get a load of side effects for medications that very often are no more than placebo in effectiveness. That if you're dealing with really severe problems, there's almost a zero placebo response rate, and the medications are far more effective than placebo. When you're dealing with the milder problems of everyday life, most of them get better with time. But if you take a medicine after going to a doctor, you misattribute the beneficial effect to the medication. And people will often stay on medication for decades when they really didn't need it in the first place.
And there have been a lot of research, thank you for that. There's been a lot of research in the UK at least, and I'm sure in America too, that about withdrawal symptoms, people getting addicted to psychiatric drugs, and also making them feel worse, or getting, them becoming more ill by having those medication. I mean, any thoughts?
And let's be clear that the risk-benefit ratio for psychiatric medication is tremendously favorable to benefit the more ill the patient is. The risks become greater in proportion to benefit the milder the condition. And one of the risks of the medication is that there'll be withdrawal symptoms on trying to stop. This is particularly true and dangerous for the benzodiazepines, the Xanax type drugs. Yeah. They are terrifically overused all around the world. They're used in older people who have terrible risks associated with them. Loss of memory, confusion, falls. They're very dangerous drugs. They're very addictive drugs. And withdrawing from them is difficult. It often takes months or a year or more. It requires medical supervision because people can have seizures and delirium. And recently, the former head of the Royal College of Psychiatry has done a wonderful thing. She had previously denied the presence of withdrawal symptoms to antidepressants. But when people pointed out that they had had these symptoms, she took it very seriously, investigated the matter, and has come out with a guidance statement from the Royal Psychiatry group, pointing out that withdrawal from antidepressants can sometimes take a long time, sometimes create severe symptoms, and people often misinterpret withdrawal symptoms to think that it's a relapse of the original condition, and that they need to stay on the medication because otherwise they'll get sick again. Whereas really the medication itself, the withdrawal from the medication, is causing those symptoms. And by deprescribing is a lot harder and requires a lot more skill than prescribing. So any doctor can write a prescription, and all too often that's what's done, without thought, without consideration of the risk-benefit ratio. Deprescribing very often takes a substantial time period, very slow reduction of dose, explaining to the patient what's happening so that they don't make that misattribution. And I think that the Royal College has done a real service to patients and to doctors by providing a re-education in something that had previously been neglected and missed.
Thank you for that. Really, really insightful comment. Thank you for that. One more comment I wanted to ask. Again, having been following your work, for a while now, and I'm sure you've seen this on social media and online. There are essentially two camps when it comes to this topic. There are people who are really against psychiatric drugs and against research, and it seems to be some people are very anti-psychiatry, right? But there are others who are, they don't really focus on or give attention to the psychological, the social aspects of mental health, as you mentioned, psychotherapy and counseling. And I know that you are critical of psychiatry and the way it has been done. But what area exactly, for the audience? What area? I'm sure that you're not critical. You don't throw the baby out with the bathwater, right? But you're critical in certain aspects, right? What are the areas that you're actually really concerned about, and you're critical of?
Well, I'm very critical of any reductionism, any simple answer. That human nature is remarkably complicated. The biology is remarkably complicated, the psychological factors, the social and environmental factors, and the spiritual factors that all interact to make us who we are, interact with millions of permutations. And simple answers are almost always wrong. So I'm very much against the biological reductionists who think that we'll be able to understand how the neurons connect to create mental illness. I think that there's a basic biological foundation to mental illness. We need to study it. We need to provide medication for people who need it, but it's never going to be a sufficient explanation. I'm equally critical of psychosocial reductionists, and the British Psychological Association is very guilty of this, acting as if there's no biological substrate, that we don't have to worry about the fact that very often psychiatric disorders are caused by medical illnesses, caused by medications, caused by substances, that everything is just the experience of the world, the stresses people have had, and the psychosocial aspect is absolutely crucial. I'm a tremendous supporter of psychotherapy, tremendously aware of the fact that the social context, that inequality, racism, that economic uncertainty, all of these are tremendous factors in mental disorder and in suicide, but they're not sufficient. None of these, all of these factors, the biological, the psychological, the social context, and the spiritual factors, all of these are necessary to understanding who people are. Not one of them is sufficient. And any group that thinks they have a simple answer to explain mankind and to explain mental disorders is always wrong, is always missing other important elements, and can't really provide the broad kind of spectrum treatment that most people need if they're going to get over their psychiatric disorders.
Absolutely, that was a really fantastic response, actually. Really, thank you for that. I know you don't have much more time. I don't want to take more of your time. Just maybe final departing message for now. You have decades upon decades of experience and learning and professional work, research. What is the advice that you could give for a kind of up and coming budding, mental health practitioner or psychiatrist, given that what we discussed, any parting advice perhaps?
Yeah, well, actually, the easiest way to put this is Google my name, and I have advice to clinicians, advice to patients, advice to families, and advice to policymakers in a series that was published about 6 months ago, I think, in Psychiatric Times. And it goes into great detail for each of these groups, what I've learned. It's a crystallization of my experience and can be read in just a few minutes. The short answer, I think most appropriate to your audience, is that in terms of psychotherapy, there's not one school of psychotherapy that has a monopoly of truth.
Yeah.
That the relationship is the most important aspect determining outcome. A good relationship is much more important than any technical factors. That it doesn't make sense to follow manuals too closely. It makes sense to know them all, but to really follow the patient. And if your mind is too much on the manual, whether it's a diagnostic manual like DSM or a treatment manual for cognitive therapy or interpersonal therapy or for whatever, if you're too worried about the manual and not worried enough about your relationship to the patient, you're going to lose the patient in the details of technique. Technique, again, is necessary but never sufficient. The relationship is always necessary and sometimes sufficient in psychotherapy. Never be dogmatic. Learn from your patients. Experience each session as an exciting moment. It's never routine for the patient. The people who come to see us are coming to us at the worst time of their life, maybe the worst day of their life. And for them, what we do and say is crucially important. And we can never know which thing we say will be something they'll remember 2 years from now that will change their life. But we should always be thinking as we work with them, what can I say now that will have a lasting beneficial impact? To never think that the next minute in a session with a patient can't be the most important moment in that person's life. So I think I would open everyone up to the curiosity and wonder of the field, the privilege we have to get to know people as well as we do, the fact that doing therapy is therapy for us, and that we learn and become better people through it, and that everyone involved in this activity is very, very privileged.
Excellent advice. Thank you for that. And it's really, as I said, it's an honor for us to host you. And hopefully in the future we can bring you again. But I know you're very, very busy. Your experience, your learning, it's for anyone really, it's really invaluable. And any time spent with you is something to be treasured and to be valued and hopeful for. So I know we're in the COVID-19 pandemic, and everyone's really, really busy. I can't thank you enough for giving us your time, giving the audience your time.
Thank me more than enough, and it's always my pleasure because I learn from each time. So thank you.
Oh, thank you, and hopefully we'll be in touch again soon. Thank you very much. Take care.
Bye-bye.